All right, I'm going to get started. So thank you everyone for coming today. My name is Matt and I'm a clinical pharmacist at the Cancer Center. So I have the privilege of working with Dr. Jones, Tolle, and Lundberg. And today I'll be presenting on hot topics in oncology, neutropenic fever. In the last couple of years there's been some updates to the guidelines, so I thought it would be a nice quick refresher for everyone, just in case you see patients on random antibiotics for neutropenic fever. So I like to start with a few learning questions. I usually go with the wordiest first and then the easier ones last, just so when people like Dr. Lundberg are here, he can follow along. So the first question is, which of the following is a Class 1 National Comprehensive Cancer Network recommended antibiotic for the empiric treatment of neutropenic fever? Is it A, ceftaroline, B, ceftazidime, C, piperacillin tazobactam, or D, ampicillin sulbactam? And I'll have the answers at the end, so learning question 2, which of the following antibiotics should not be used for neutropenic fever with MRSA pneumonia? Is it linezolid, vancomycin, telavancin, or daptomycin? And then the last one is a true or false. Moxifloxacin is an oral fluoroquinolone which has broad spectrum coverage that includes that against Pseudomonas. True or false? Okay, so here are the learning outcomes of today's presentation. The first is to define neutropenic fever and the risk factors associated for developing this infection. 2, to identify the subset of patients that are eligible to receive neutropenic treatment in the outpatient setting. And then 3, recommend empiric antibiotics based on current national guideline recommendations. And so here's a list of the guidelines that are out that make different neutropenic fever recommendations. It's a little confusing because there's 3 of them. And so now it's a little bit easier than it used to be. When I used to give this presentation to my pharmacy residents at my facility, IDSA, American Society of Clinical Oncology, and NCCN all put out different guidelines, and they didn't overlap very well. So you kind of got to pick which one you liked, and you were never wrong. But you also didn't have very clear guidance. Now IDSA and ASCO, or American Society of Clinical Oncology, they teamed up and they came up with 2 guidelines, one on prophylaxis and one on outpatient treatment. And then we still have the NCCN guidelines, which are updated yearly. So ASCO, IDSA, they update probably ideally every 5 years, but really every 6 to 10 years. And then NCCN, you see frequent updates, minimally yearly. But now they overlap a lot more. And since they're collaborating together, it's making it easier as a clinician to kind of figure out what the best guidelines are. And so, neutropenic fever, why did they give me 45 minutes to an hour to talk about this? Why is it important? Well, for our cancer patients, it's an oncologic emergency. It's a common source of morbidity, mortality. So with regards to that morbidity, 25 to 30% of our patients, they're going to experience hypotension or heart failure, renal failure, hepatic dysfunction. And then the mortality, it's actually kind of a high number. At a baseline, our neutropenic fever patients, there's an 11% rate of mortality. Those neutropenic fever patients that come in additionally with sepsis, that number bumps up to 50%, so 1 out of every 2, which is a lot. And then when we're considering this, the usual signs and symptoms of an infection are often absent. Sometimes our patients only present with fevers, and that becomes a little more convoluted too when you have our cancer patients who are on steroids, because steroids can mask fever based on endotoxins, so then it can just be an overall confusing situation. And so in a percentage of our patients, a high percentage, we do get neutropenic fever. In solid tumors like your breast, your lung, 10 to 50%. But then when you get those cancers that are affecting the bone marrow itself, up to greater than 80% can present with neutropenic fever. And so that's why it's so important, because if you're presenting with this neutropenic fever, you're septic, you have a 50% mortality rate. That's why we treat it as an emergency. And so then, what's causing, what's making us susceptible to it? What's causing this from happening? Well, it's one of two things. The malignancy itself can affect the bone marrow and cause that neutropenia, or the chemotherapy that we give can directly affect the host's immune system and deplete the neutrophils and white blood cells that way. So there's a couple different ways to do it. And then when we're talking about febrile neutropenia, we really need to get a firm understanding definition of it. So previously, before these new updated guidelines, there was some differences in how they defined fever, how they defined neutropenia. Now that ASCO IDSA teamed together and they're actually talking to NCCN, all the guidelines are the same. Some institutions still may have some slight differences in their determination, but overall, we define the fever, which we like to measure orally ideally, not always applicable, but we define that as a single temperature of 38.3 degrees Celsius or higher, so 100.4 degrees Fahrenheit as a single measurement, or if they're 100 degrees Fahrenheit sustained over the course of an hour, we're defining that as a fever in those patients. Then we measure ANC to determine if they're neutropenic or not. Guidelines define that as less than 500 neutrophils per microliter, or less than 1,000 with an anticipated decrease to less than 500. Now, you may see some people say 1,000 is neutropenia, 1,500 is neutropenia. Guidelines say 500, but there's still kind of that disparity since that's new guideline recommendations. And then we take it a step further and we define profound and prolonged neutropenia. So that's when we're expecting neutropenia to occur with less than 100 for greater than 7 days. And so that's going to come up quite a bit during the presentation because that's to guide prophylaxis and things such as that. So I never thought there'd be so many different ways to measure a temperature and how it was impactful. So I read like 4 articles on it, like meta-analyses. People have grouped these huge. But, so, ideally, we want to give oral. It's the best representation for our patients. The guidelines recommend oral. Their recommendations are all based off of that. But then we have a very common side effect in our cancer patients, that mucositis, that inflammation of the throat, the esophagus, trouble swallowing, trouble, very painful. So then, it's not always ideal to put a thermometer in that painful area. So then the recommendations based on all those readings I did was tympanic. But again, these all come with their own pros and cons. So if you're trying to do oral in a mucositic patient, you can have an overestimate of temperature. In the ear, if it's the patient's dependent ear, so they hear the best out of their left ear, you're oftentimes going to have a higher reading. If it's full of earwax, you're oftentimes going to have a lower reading. And so why is that important? Well, if it's falsely high, we can overtreat with antibiotics. If it's falsely low, again, oncologic emergency. So you're always weighing that risk-benefit. So ideally, oral temperature. If not, use the ear. If anyone's interested in all those meta-analyses, I would gladly email them out. Dr. Lundberg's not here, but I'm sure he'll want it, so I'll just CC you on that email. ANC calculation. So how do we calculate the ANC? Well, fortunately for us, the lab and all those fine computer programs, they do it for us. So you really don't ever have to worry about it. But if for some reason you don't trust technology, here's how you calculate the ANC. So to calculate that, it's your white blood cells times your percentage of bands plus your percentage of SIGs. Some people also report that out as percentage of neutrophils, so it kind of just depends where you're practicing, how they label things. But so say you have a patient with a white blood cell count of 1,500, SIGs and bands 30 and 5 respectively. Your ANC calculates out to 525, so teetering neutropenia, I would probably consider neutropenia based on that. So then, which sorts of patients should we really be cautious on? Which ones are at the highest risk for neutropenic fever occurring? Well, patients 60 to 65 or older, those patients are inherently at a higher risk of getting it. Their performance status. So we like to look at our performance status based on ECOGs. So if you read a Dr. Jones note or a Dr. Lundberg note or a Dr. Tolle note, we write out those ECOGs, and that's just telling, in a simple term with less writing what their status is. So if you're an ECOG of 2 or greater, you're at a higher risk of neutropenic fever. I'll present a table in a little while kind of listing out what those numbers mean as a quick reference, but with ECOGs, 2, 3, and 4 is worse. If you ever see a 5 in the chart, it means it's dead. Not sure what you're going to do in the chart then. Comorbidities, if you have renal dysfunction, hepatic dysfunction, pre-existing autoimmune diseases, or direct bone marrow involvement, you're more likely to develop neutropenic fever as a cancer patient. If you have a low pre-albumin or albumin, you're at a higher risk, and if you've had previous neutropenic episodes. So if you've had this febrile neutropenia, you're at about a 75% chance for it to happen again. So that's why it's really important that we reevaluate after every cycle to ensure that we're optimizing therapy. And then lastly, I discussed the type of malignancy, but also the treatment of malignancy can affect your risk as well. So here I have listed out a whole bunch of chemotherapy drugs. This is more for informational purposes. Dr. Fredrickson, don't worry about memorizing this. You just ask Dr. Lundberg. He had us build those right into the power plan, so no thinking needed. But so then, we've defined what group of patients are at highest risk, or what risk they're at. So what do we do to prevent neutropenic fever? Well, the first thing we can do is we can give them primary prophylaxis with growth factors. So that's our filgrastim, our pig filgrastim, and the biosimilars that are associated with it. And so NCCN does a really nice job of laying out a stratification as to who needs to get G-CSF and who doesn't. And so those patients, when they studied them in clinical trials, in the patient trials that had greater than 20% febrile neutropenia, we recommend giving this G-CSF. In that 10 to 20% range, it's kind of questionable, but they do give additional guidance on that. And then for less than 10%, we don't have to give it. That's a low incidence. Again, this is primary prophylaxis. So after our first cycle, we'll go back and we'll reevaluate the second cycle. And so that intermediate, really what you're looking at is you're saying, in studies it was 10 to 20%. Let's take it one step further, look at our patient outside of what they're getting treated with. And if they have additional risk factors, we're more than likely going to give it. If they don't have risk factors, we can just watch and continue how we were normally. Here are the chemotherapy regimens that are the highest risk of febrile neutropenia. Again, just put this in here just for perspective. We have lots of breast cancer patients on TC. We actually have 2 EPOCs running right now in the outpatient, and that's an inpatient regimen. We have doxorubicin, topotecan. So these are common regimens that we're seeing. And so a lot of our patients are actually going home on these growth factors. Here's our intermediate risk, and so this is our common colorectal, our more common breast cancer regimens, non-small cell lung cancer. So really, the point of these 2 slides is to show that, when you're considering that intermediate to high risk, that's a huge population of ours in Fond du Lac, based on what we treat with. And so the growth factors, we have filgrastim, TDO filgrastim, and then the biosimilars. And 9-ish months ago, I did a presentation on biosimilars that showed they're equally efficacious, highly similar, no clinical meaningful differences. And so with these biosimilars, NCCN gives them all a Category 1 recommendation. And so what that means in the world of NCCN is they have robust literature, and they all work just as effective. You want to typically start at 24 to 72, 96 hours after chemo. And there's how it goes. And that's a daily one. So then the next one is our long-acting one. It's the one-time shot. It's pegfilgrastim, and then the biosimilars. Interestingly enough, when NCCN published their most recent guideline update, they only gave pegfilgrastim a Category 1. we used the biosimilars. The data just wasn't out there at the time of publication like it is now because they were just brought to market. So I fully anticipate that the next update, they're all category 1. What I find really interesting is now we are getting emails, letters in the mail from all the major insurance companies that cover our patients, and they're each dictating a different biosimilar that's their preferred formulary agent. So they're taking these recommendations, they're finding what's the cheapest, and they're telling us that's what we have to give to our patients, showing that they've accepted that these are interchangeable medications. So we can give growth factor. What else can we give? Well, we can give some antimicrobial prophylaxis. And so this can be antibiotics, antifungals, antivirals. And so NCCN, ASCO, IDSA, kind of the same, just a few slight differences. But so our patients at the highest risk are patients with hematologic malignancies. We're going to give them likely both an antifungal and an antimicrobial. That profound, prolonged neutropenia, since we expect their immune system to be knocked out for quite some time, we're going to give them both. When we get into regimens with high PCP rates, we add on things like Bactrim or Dapsone or blinking. And then so here is a nice sheet by NCCN that is showing the low, intermediate, and high risks. And so really on this one, what I like to show is for antimicrobial prophylaxis, the gold standard is levofloxacin. It has the most studies done behind it. Other alternatives, some people think you could give Cipro. It's okay, Cipro doesn't have as good a gram-positive coverage, and the gram-positive coverage it does have, you're seeing increasing resistance, particularly to like your pneumo. But outside of that, we see as alternatives cefodoxime, so your later generation oral cephalosporins or Bactrim. So predominantly levofloxacin, 500 daily during those neutropenic time frames. So then we get to antifungal. And so typically what you're going to see is we're just going to toss on fluconazole because it's cheap and give that to most patients. The only difference now is that they're, I don't know how to use this high technology. I moved from a small town. And the only difference here is when you're looking at your AML or your MDS, so your myelodysplastic or your acute myeloid leukemias, there are studies that show that posaconazole is superior to fluconazole in both morbidity and mortality. So now the category 1 recommendation is posaconazole in that particular cancer. The issue we run into is posaconazole. There are 2 different formulations. There's tablets and liquid, not interchangeable. So when we get our patients, we start on the tablets, they get mucositis, the doctor wants to switch to liquid, not 1-to-1. It's also very expensive. So that's why they do have 2B recommendations, which contain VORI and fluconazole. So you will see those patients on those ones, but a lot of times that's based on cost and access issues. So, but just for everyone's reference, posaconazole solution, 200, 3 times a day. Posaconazole tablet, 300 twice a day load, and 300 daily. Okay, so 200 3 times a day, liquid, essentially 300 daily tablet. That's the difference. And then here we have our viral infection. We pretty much see acyclovir for those patients that is necessary. And most times it's patients who have hematologic malignancies and have a history of seropositive disease. So then, how do we evaluate these patients? Well, ASCO, NCCN, IDSA say we want to do a quick physical examination of the patient within 15 minutes of coming through the door. And we ideally want to start antibiotics within 60 minutes. A lot of that's very consistent with surviving sepsis guidelines. Again, 53% of septic neutropenic fever patients deceased. That's why it's important. So we want to look at their comorbidities. When was their last chemo? Have they been on any antibiotics? What are their medications? And then do they have any devices? Do they have an implanted pacemaker? Do they have a central line, a port? Where could the source of infection come from? Relevant exposure, cigarette smoking, marijuana. I think the marijuana issue is kind of interesting because we're seeing more and more patients trying to use these alternative methods to help cope with anxiety, peripheral neuropathy, nausea, and vomiting. There's been case reports out. I know case reports aren't entirely robust, but in hematologic malignancies and marijuana use, there's an association of invasive fungal infections. So it's just like something to be aware of, because I think a lot of times we hear, oh, this marijuana, this CBD, this is curing all. I think the data behind that too is up and down, spotty, and then with these case reports, it's just something to keep on your radar, that if you're having those patients come in with lung issues on marijuana, hematologic malignancy, you may want to start an antifungal earlier than you normally would in the course of a neutropenic fever treatment. Physical examination, lungs, abdomen, catheter sites, mucous membrane, skin, so your typical sites where things might happen. Are they having trouble breathing? Are you hearing rales? Are they hypoxic? At a minimum, we want to get a CBC with diff and a CMP just to see where renal, hepatic function is. Are they truly neutropenic? And then consider chest x-rays, urinalysis, things like that, depending on signs and symptoms of the infection that is going to take place. Then NCCN, they want you to grab a couple sets of blood cultures, ideally one peripherally and one with like a central venous catheter if possible. But if you can't do one or the other, 2 cultures from one site, it's fine. Just make sure you're getting multiple cultures. Again, we want to make sure we get cultures, but if it's going to delay empiric antibiotic therapy, similar to sepsis guidelines, don't. The antibiotics are more valuable in the long run than the cultures are. Can't tailor it as nice, but you can prevent death easier. And then if there are those sites that we're considering and viral diagnostics. And so again, you guys are the physicians, not me. If you can tailor this all you want, these are just recommendations. To me, I struggle trying to tell doctors how to do an HMP because I just sit in my ivory tower and tell you that you dose something wrong. So then our patients come in and we did this robust HMP, neutropenic fever. So then we can risk stratify them into one of 2 groups, low and high. And so our low risk groups, well, you have to meet all of these criteria. So you have to be outpatient at diagnosis. You can't have anything that's going to require you to be admitted independent of the neutropenic fever. You want to make sure that that's not a prolonged, profound neutropenia. You have a good performance status, so you're a low ECOG. You don't have any hepatic or renal insufficiency because we know that that's going to increase morbidity and mortality based on previous risk factors discussed. And then a mask greater than or equal to 21. And so what a mask is it's a really long multinational association for supportive care in cancer. Really long title. All it says is, hey, we're going to give you another thing to evaluate risks for neutropenic fever. So at NCCN, they tell you, here are your risks. This group was like, oh, let's put it into writing. So yet another calculator you can go to UpToDate on and click and punch in all your factors. There, I don't think we use it very often. And so here's your ECOG scoring: 0, fully active, able to do everything pre-disease. 1, a little bit restricted, but you can carry out light work or, your normal things. And then 2, 3, 4, that's where it's getting progressively worse. 5, death. But again, you have to be pretty much in good standing to be treated on an outpatient basis. Here's the mask score. So it's essentially taking those risk factors that we discussed earlier, putting numbers with them, and then determining where should your patient be treated. And so, opposite of your low risk, it's the same stuff with the addition of if you need a stem cell transplant or have a history of it, if you have pneumonia, or if you have terrible mucositis, you're also getting admitted. Okay? So then we're deciding this is what's helping us decide inpatient versus outpatient. So those low-risk patients, we can either treat them at home in an ambulatory clinic, or if they're not suitable candidates, we can admit. Our high-risk patients, we will admit them to the hospital, so beautiful St. Agnes. And so things to consider with those outpatients in particular, lab results. So we know the ANC is going to be low, but we want to make sure hepatic function, renal function, those sorts of things aren't out of whack. The patient has to agree to go home and take the meds or follow the instructions that are given in order to cure it. we could treat people, a patient all day, but if they're not going to take the meds, they're coming back. Do they have access to those emergency facilities? Because if they spike a fever during this, they need to come back and get admitted. Do they have the home environment necessary to take these medications, to go into the clinic for IV antibiotics if that's what's determined? Or can they even take them? Do they have nausea and vomiting? Are they able to take other orals? Have they had fluoroquinolone prophylaxis? And the reason that's important is fluoroquinolones are the only oral antibiotics that have pseudomonal coverage. So if you were being prophylactic with fluoroquinolones, and you spiked a fever and got neutropenic, we need to put you on something that covers Pseudomonas. There aren't any outpatient options for it. And then if they have a feeding tube, we need to know where the tube goes. Is it a G tube? Is it a J tube? Because that's going to inherently guide some of our decisions based on absorption of these antibiotics. And so here is a nice up-to-date chart of all the bugs that it could potentially be. Really the things we're looking at: staph, strep, enterococcus, Acinetobacter, Pseudomonas, those sorts of things. So are more common gram-positive, gram-negatives, but those ones where you can also run into multi-drug resistance. And so patients can get IV antibiotics at home if you know the bug. They could get IV in the clinic or at home plus an oral, again, if you know the bugs. And then empirically, NCCN recommends Cipro and Augmentin or moxifloxacin. I don't see a lot of moxifloxacin used because the last time I checked, it was still pretty expensive for a lot of patients, and it's just becoming a lower, cheaper option, but still pretty relatively expensive. Cipro, poor gram-negative coverage, so that's why you have to add Augmentin on board. And then the other option is levofloxacin. And so here are just a few pearls. Levofloxacin, you got to adjust it for renal function. It does cover Pseudomonas. Moxifloxacin doesn't cover Pseudomonas, so that's one of the concerns with that one. Cipro, 4 gram positive coverage, covers Pseudomonas, renal function adjustment. And then Augmentin does not cover Pseudomonas, anaerobic coverage. And if you have a penicillin allergy, guidelines recommend using Clinda instead, but it still has to be a combination, Cipro plus Clinda, because you have to get that additional gram-positive coverage. Fluoroquinolones. I think we're seeing a lot of safety alerts coming out. I think our antimicrobial stewardship committee sent out an email with a pretty robust list of, you should probably use this instead because of safety concerns. In our cancer patients, it's always that risk-benefit. The studies have shown the benefits with fluoroquinolones, so that's why in a lot of those recommendations you're not seeing them tell you not to use them in neutropenic fever patients. FDA is putting up these safety communications, so I just like people to be aware of it. This was a recent one. So I think the newest ones that I've heard about are the hypo and hyperglycemia. I had a patient call 3 weeks ago and asked if we look at what other meds they're on because he went hypoglycemic on levofloxacin, and then he recited to me that 7 patients died of hypoglycemic coma based on the FDA safety communication, and said it was ridiculous that we let that go through. Then I had to explain to him it's always a risk-benefit. Neutropenic fever patients, fluoroquinolones, gold standard, hypoglycemic coma, 7 patients died. Septic neutropenia, 50% of all patients died. He decided to monitor the blood sugar a little closer. But that's, I bring this up because those are the conversations that are coming up, and patients get kind of riled up and upset, rightfully so, thinking that maybe you missed that, but the reality is just educating and re-educating because FDA puts it out, and then you hear about it in ABC and CNN, and it's on all the news outlets about these antibiotics that are bad, chemotherapy that kills, and we see it every day. So then my next thing with antibiotics is a penicillin allergy. And so I like this one because it says, are you allergic to penicillin? Yes or no. Are you sure? And so for me, for example, my mom said when I was really little, I got hives to amoxicillin and penicillin. If I'm ever under any of your care and I am neutropenic and septic, give me all the penicillins. I'll be okay. I don't even know if it's real, and that's what we need to assess with our patients. Is this truly an allergy? Because those beta-lactams are very, very good for the treatment of a lot of these infections. So we need to make sure that we're using appropriately. So 9 out of 10 patients who actually have a penicillin allergy, self-reported, it's not a true allergy. So that's, less than 10% of the population who say they have it and actually have it. So then here are things you can look at, what medications were you on? What was the type of reaction? And so what we're trying to assess, is this truly an anaphylactic IgE related reaction? I have not noticed it at this facility, but at other facilities I've practiced at, I have seen that all antibiotics give GI upset and all narcotics give GI upset on their allergy list. That is not an allergy. I know you guys are smart enough to know that, but I'm just going to echo it because I had seen other antibiotics used because I was told they had an allergy. GI upset is fine. So now if my patient has a feeding tube, we see a lot of head and necks around here lately. I feel like we're seeing a lot more head and necks than when I started in this year process. And a lot of those, since they're getting radiated to that area, they can't eat, they get a tube put in. If you get a G tube that goes right to your stomach, sure, give them all the normal antibiotics. We know they're going to absorb. When you get into that J tube, it gets a little questionable because when they do absorption studies, sometimes they don't even look past the stomach. Other times they do and they don't absorb. Fluoroquinolones, one of our gold standards. Cipro predominantly absorbs in the duodenum. So if we give it in a J tube, it bypasses the duodenum. There are case reports that say if you jack the dose up, it's still effective. Levofloxacin, moxifloxacin, don't have that data. So if you have a J tube, you cannot put it down the J tube. You would be bypassing where it absorbs, ineffective. Amoxicillin clavulanate, they studied it in the jejunum, it's totally cool. And then clindamycin, there are no studies to say neither here nor there. So if you think they're a good candidate, very low risk, and you try them on clindamycin through the J tube, you just have to look to see, are they getting better or are they getting worse? That's the unfortunate issue with something where you're not necessarily sure based on the literature. Here's some typical antibiotic dosing. So you want to check the patient after, daily for 3 days, make sure that they're responding, they're not having any toxicity, they're actually taking it. And that can be clinic or home visits. The reality is our patients aren't going to come in daily for 3 days. We just have a follow-up call most times. And then if they were to need to come back to the clinic, these are the reasons. Do they have a culture that's positive and we're not covering the bug? Do they have any new signs and symptoms? Is their fever persisting? Can they take it? If you're constantly puking your medication up, it's not absorbing. We have to do something else. And so if they're hospitalized then, so your high-risk patients, and transitioning a little bit, we have to cover Pseudomonas. We have to have broad coverage. We want to look at their history. If they have a history of multi-drug resistance, we need to treat as such. Look for colonization. Antibiograms are awesome. I love looking at those because it makes it less likely for me to screw up. Because it tells you, oh, these antibiotics are going to cover these at what percentage. It's helping guide that empiric therapy. And then considering bactericidal versus bacteriostatic. So are we killing the bug or are we just preventing further growth? And so here's our empiric intravenous antibiotic therapy. And so I went off our antibiogram and put those little dollar signs like they had so that when the director of pharmacy asks why I'm promoting expensive medications, I can say, no, I put the dollar signs. That's on the physicians. Turf the blame as I usually do. And so the big ones are cefepime, Zosyn, and so with the piperacillin tazobactam, it's the bigger dose and it's an extended infusion. So essentially all we're trying to do is keep time over MIC is how it's going to kill. What I would do is I would give the first dose traditionally, so that 30-minute infusion, just so you get the concentration out right away. And then your next dose, give it 6 hours after and start this every 8 hours. So essentially loading the patient up. Then we have our carbapenems. You'll notice ertapenem's not on there. Ertapenem does not cover Pseudomonas, so don't give that one. I think meropenem is our formulary preferred agent, but I practice in the cancer center, so I'll let the inpatient pharmacist call you on that one. And then a lower recommendation is ceftazidime. They say, hey, we probably don't want to use it if you don't have to. There's increased breakthrough infections associated with it. So here's our antibiogram. I highlighted the big 3 antibiotics, meropenem, Zosyn, and cefepime. It can be kind of hard to read, but the one thing I like to point out is if you look at cefepime, everything's probably like 92 to 100%. of the bugs that we're trying to target, which means it's a really good choice. And so, is one better than the other? I mean, they recommend, you know, the 4 different ones. And so the answer to that is no. They did a study with cefepime versus imipenem, no difference. Zosyn versus cefepime, there was a multivariate analysis that said Zosyn maybe had a little bit better treatment success. It wasn't a huge amount, so we haven't seen a practice change. And then the big one that came out was cefepime versus beta-lactam meta-analysis. Increased mortality with cefepime. So everybody got into this huge, we can't use cefepime. That's, I mean, it was built on freighters, UWs, Rs, Marshall Briggs, but that was the standard across the country. And so FDA was like, well, pump the brakes. They pulled 50 trials together, evaluated them in a huge meta-analysis, and said, nope, there was absolutely no difference. So that's why we see cefepime on the front line still. Do we need to add to our initial therapy? Well, depending on how the patient presents, so if they have the abdominal pain, you could, if you suspect C. diff, if they have perirectal pain, you probably want to cover anaerobes. Cefepime does not cover anaerobes. Sorry. Too many buttons. Somebody small-minded like me, that's my wife right there. I need one button. Diarrhea, if you think it's C. diff, vancomycin, oral vancomycin, not IV. You start IV vancomycin for C. diff. Paul will yell at you, because he'll have to monitor it. UTI, you don't have to add anything. Lung infiltrates, again, worrying about invasive fungal infections, PCP infections. Cellulitis, you're going to want to add on additional gram-positive because odds are it's either going to be a staph or a strep. Worry about methicillin-resistant staph. Vascular access, add vanco. Vesicular lesion, worried about your herpes-type infection, your varicella-type infection, you're going to want antifungals, CNS, lumbar puncture, high-dose acyclovir. You know, so we're essentially, if we can locate the source, we're adding on the additional empiric antibiotics to cover what those would typically spew out. So what about gram-positive? Should everyone get it? Well, what would an expert in oncology say? They would say no. So I was tinkering around in the basement and I found this photo of Dr. Lundberg blown up. And unfortunately, he's on, you know, one of his vacations doing mission work as he does, which is pretty cool. So now he's not going to get to see that I put this photo in here. So I'm going to have to strategically place the blown up photo somewhere in the cancer center so he can see it. Those aren't real patients, so this is not a HIPAA violation. And they don't work there, and they haven't worked there for a long time. So this I think is 10 years younger Lundberg. If anybody wants a copy, I'll get a few blown up. And so who should get this additional MRSA coverage? Well, those are the hemodynamically unstable patients. So those are the patients going to our ICU. Those with pneumonia, positive blood cultures, severe mucositis receiving fluoroquinolones and using fluoroquinolone prophylaxis, now using ceftazidime. Not great gram-positive coverage. And so what's available? Really, the ones I recommend, vanco, dapto, linezolid. They each come with their pros and cons. Vanco, linearly adjusted, you have to get appropriate troughs, takes a little bit to even see some killing. Dapto, do not use it for pneumonia. It has theoretical great lung penetration, but our surfactants inactivated immediately. So do not use dapto. And then linezolid causes myelosuppression. We have these patients who already have myelosuppression, risk benefits. We got to keep doing that every time. So is vancomycin the answer for everything? Well, the answer, based on an oncology expert, is no, unless ID tells you to. Then do whatever ID says. It's kind of my motto. And so, why not? Well, the odds ratio of developing an AKI is 3.5 on vanco versus vancomycin versus with other beta-lactams. In my previous organization, we did a retrospective analysis of all our patients over like a 6-month period. 1 in 3 went into kidney injury, consistent with the literature. Literature now says 30% will go into kidney injury. If you use cefepime vanco, only 11%. So a consideration. I have not done any analyses here since I don't touch the inpatient side, but I would anticipate you would see that same because that's kind of a national-wide thing. We actually at my previous organization had vancomycin ID restricted. It was causing so much of a problem. Acceptable alternative, cefepime flagyl backbone. Zosyn has that added anaerobe coverage, so if you add it on with flagyl and cefepime, you're going to be good. MDRs, I think we know how antibiotic resistance happens. I find it interesting how big of a topic this is now. The World Health Organization puts out a whole week each year, and their motto this last year was think twice, seek advice. So I think that's kind of telling in itself why it's important we need to be using it appropriately. If you have a viral infection, don't use it. Make sure you're targeting it as we discussed. Getting the correct dose, continuing educating and holding colleagues accountable. So I got to give a presentation, which was pretty neat. And then how do we do it in our cancer patients specifically? Well, we make sure we're risk stratifying and giving the appropriate patients prophylaxis, and the ones that don't need it, we're not. We're targeting and we're discontinuing. And so who's at risk for those I discussed a little bit earlier. And that's where we're going to want to look. We're going to take that risk, we're going to take our antibiogram, we're going to give them the best agent to cover what we think they may have. List of the different resistant bugs and how to treat them. I would be super sad if I ever had to see colistin used, but at some urban areas, they had to use that because of superbugs. So I think we're lucky with regards to Fond du Lac that we have a favorable antibiogram. This is just an FYI when you treat with growth factors. If they were already on it and they're still on it, just keep on with it. If they got the long-acting pegfilgrastim, they don't need it. If they didn't receive it and they have risk factors, start them on it. If not, you don't have to. Kind of just along those lines, similar risk factors that we've been talking about. And then how do you monitor them daily? Well, if they're stable or improving, fever decreasing, you don't have to change it until cultures come back. If they're worsening, you need to either change antibiotics, and if at 3 and 5 days they're still worsening, add those anti-mold, antifungals, things like that, trying to hit those bugs that could be there, but we didn't think they're not usually a high percentage of causing agents. And so when we pick our antifungals, we're going to look at what we think is causing it, the toxicity, are there any drug interactions, and the cost. This is essentially just showing you, like, did they get fluconazole prophylaxis? No, start them on something different. Or yes, start them on something different. No, you could probably start them on that. Here are our different durations. IDSA does a really nice job of putting out specific guidelines too, and CCN here is trying to compile those together. You know, the other ones here, HSV, VZV, so your herpes, you gotta keep an eye for that. Brings me to my last pearl on that is, in our obese patients, do not use actual body weight. The way that it distributes within the body is of that of an ideal body weight. So if you do actual in a morbidly obese, you're running the risk of putting them into things like renal issues. When you're getting our super morbidly obese patients, it becomes questionable. There's some scant data that says, hey, you could maybe do an adjusted weight, but really ideal body weight in anyone who's not in the ICU and whose any size is appropriate. If they're greater than 40 in the ICU, you may want to do an adjusted. How do we prevent neutropenic fever? Well, vaccines, prophylactic growth factors, antibiotics, and hygiene. Plants and dried fresh fruits aren't allowed in the flowers, aren't allowed in the rooms. And you want to avoid prolonged contact with environments with high concentrations of airborne fungal spores. I didn't really know what that meant. That's construction sites or doing prolonged gardening, which is like a real thing. We have a lot of patients who they garden for hours per day because it makes them feel better, it gives them energy, they enjoy it. So to even ask that simple question when you're doing your H&P, what do you do for those? Here's your vaccination recommendations. The big takeaway that I like to point out here is don't give them live vaccines. There are a few different live vaccines. Varicella is live, with the exception of Shingrix is out now, which is an inactivated varicella vaccine, but nobody can get it. They brought it to market and it's on back order indefinitely. And then MMR is also a live one. So back to our learning questions. Which is a class 1 recommended antibiotic for empiric treatment of neutropenic fever? And that one, I don't know how to use the thing because I'm not smart, is Zosyn, piperacillin tazobactam. Ceftazidime is a 2B. Ampicillin sulbactam doesn't cover Pseudomonas except pteroline. IB should really tell you to use that. Number 2, which should not be used for MRSA pneumonia, and that one is dapto, gets inactivated by lung surfactant. Probably shouldn't use telavancin either, but it would cover it. Again, that's an IB thing. And then 3, moxifloxacin. It does not cover against Pseudomonas. Only cyprolevofloxacin. Questions?